Can you see my screen?
Yes.
This is a patient who is status post liver transplant, and after transplant, patient developed abnormal LFTs and was found and had been managed for ischemic biliary ischemia, so ischemic cholangiopathy after liver transplant, and has been getting ERCP with dilatation. The patient's hepatic artery is totally normal; it's patent, and the so that it's over the after a year out after transplant, it's gotten better. The LFTs has normalized or stabilized after an acute exacerbation. So I wanted to share there's a classification of biliary ischemia that we see after transplant imaging, and I'm going to share a diagram from a paper that I will pull up. No, that totally okay. So this is the diagram from a paper that I'm going to show you in a second. Actually, this is the paper here that was published in Transplantation, a multi-center study, and within it, in patients who have patent, so non-vascular, right? No hepatic artery thrombosis. These are non-vascular ischemic cholangiopathy. There are different subtypes. So the diffuse necrosis, normal should, post-transplant normal, and then you have diffuse necrosis where you have intra and extrahepatic biliary ductal dilatation with strictures, and then multifocal progressive. This requires follow-up imaging. So starts with mild stricturing, but then progresses, and then confluent dominant, and then the minor form. So this stays minor. And this is important to know because patients who have either diffuse necrosis or multifocal progressive, they almost always require retransplantation. In contrast, patients with minor form or confluent dominant can be managed conservatively with ERCP and balloon dilatation and don't require transplant. So our transplant hepatologists have asked that we classify these if we can. So I just wanted to make people aware that that is something that we should try to do for our transplant patients if possible.
Super interesting. What is the name of this grading system?
I don't think there's a name for it. It's just
Okay.
it's a subtype of ischemic cholangiopathy, and this is felt to be due to ischemic time after after having it removed from it's in DCD patients. So presumably, the transplant has been just ischemic while it's waiting or being transferred, et cetera, et cetera.
Got it. And what did your patient end up having? What did you end up classifying it as?
A multifocal progressive.
Okay.
So it started
but
out.
It got better, you said.
Yeah, it did stabilize. So it was managed with ERCP and balloon dilatation. It got acutely worse, but then it plateaued and now has been stable / improving. So I suspect there's probably a spectrum of it. Like it doesn't just continually progress. There's probably, cases where it gets better and others that stabilize. So as long as they're not an acute liver failure that would warrant immediate transplant or relisting.
Awesome. I'm glad yours is getting better so they don't need a retransplant. And I did not know about this. Every time I see biliary ischemia, I always think about hepatic arterial thrombosis, not necessarily the prolonged time between, the transport time, et cetera. So, okay. Okay, so this is a patient with a pelvic mass. What do you guys think about it? Where do you think it's coming from? What would you say about it?
It's protruding out. So I see the lower vagina. So it's like in the region of the lower vagina introitus.
Yeah, and it's pretty external and it's really anterior. So we've got the urethra here. I don't think we see the vagina super well, but it's kind of back here. So it could be arising from the distal vagina or even the labia and the rectum.
Vulva, yeah.
So yeah, we were like, is it arising from the distal urethra, etc.? Here it is on the axials. And on physical exam, they told us this looked like a clittoral mass. So here's the urethra, and it looked like it was like anterior, arising externally anterior to the urethra from the clitoris. So here it is again on the space, on the high resolution. So we've got a large, pretty homogeneous appearing clitoral mass, which is a rare thing. And I'll just, this was the enhancement. So it was avidly enhancing. So obviously, like, this is something, I just wanted to kind of show this as a show and tell. We wouldn't necessarily get the diagnosis, but it's something that needs to be removed. Any guesses on what this could be? It was kind of intermediate on T2.
Yeah.
Strict diffusion, avidly enhancing.
I would put sarcoma, like a stromal kind of tumors in there. It doesn't have like normal, T2, or not normal, but benign appearing T2 signal. So I wouldn't put benign. I mean, I
Right,
guess
like it
could be,
doesn't look
but
dark like a leiomyoma kind of thing.
yeah, like it has the elo gray.
Yeah. Excellent. So this was a sarcoma. It was actually a low-grade spindle cell sarcoma. So just, thinking about the clitoris, it has a lot of muscle, nerves. So your general differential is going to be things like a sarcoma, rhabdomyosarcoma, leiomyomas, schwannomas, so things that have muscle and nerves in them. But either way, it has to be removed. And luckily, this was a low-grade one. But I just thought it was interesting because I've rarely ever seen, I think this is the first clitoral mass I've seen. So cool. And actually, they do have a good prognosis. They were able to resect the whole thing with negative margins. So yeah, it can be fully resected.
This is a patient who came in with a uterine mass. So this is the post-con. It's enhancing. It's T2. Let me show that again right here.
It's kind of like intermediate, but it seems pretty well circumscribed.
Yep, exactly.
There wasn't necrosis. Was there any hemorrhage?
No necrosis. Here's the pre-T1. No hemorrhage. And then the diffusion, the high B value diffusion is, well, here's the ADC while I look for the.
So that area is fine, but the other ones, I think your ROIs are too small.
Yeah, I think, let me see, let me take you back to the ADC. Where's my ADC? Yes, so that area, right? I think you said it was 25, mean area should be 25, is that right?
It should be between like 25 and 48. So that one is fine. The area, the second line down where it says 26, but then if you go to your next image where you had these guys are too
tiny
small.
ones. Yeah. And
because vessels can be really dark. So you just want to make sure that it's larger than the size of a vessel, but not like huge ROIs.
Yeah. And they don't meet the ADC cutoff anyway. So.
Okay. And then, so did any of them? So we were talking about that radiology consensus paper where they said like a ROI less than, an ADC less than 900 is suggestive of a leiomyosarcoma rather than a leiomyoma.
Yeah, only if it, meets the criteria before, right? So the first criteria is that you have to have enhancement. So this lesion is enhancing. Then after that, it has to have T2 intermediate signal or T2 hyper intense. And this one is T2 intermediate. Then you go to high B value ADC, and it has to be signal higher than endometrium. So here is our high B value. And the endometrium is like along the lateral aspect. It's being displaced, but it is higher than the.
Quick question: what B value are you using?
This one is an outside MR, so the B value I don't, let me see. I think they acquired it at, where did they acquire it at? I gotta look up. Let me pause my screen share so I can look it up. It doesn't say on the .com.
So you're
It
not
doesn't,
sure about the B value, but the reason I ask is because we actually got in a debate about this week, and we're still trying to figure it out. But we were using a B value of 800, and I spoke to Nicole Heineman, who wrote that paper, and she said you have to use a B value of 1,000.
1,000, yeah.
And the ADC values are not reliable if you use a lower B value. Our physicists have said that it shouldn't matter. So we're still in debate about this, but we're trying to switch to B 1,000. So just a point out there for other people who might not be, who might be questioning the same thing.
So I don't understand. So she's saying that the B value has to be 100 so that the ADC value is accurate?
It has to be 1,000. You have to be using the high B value, and it has to be a B value of 1,000 to use that ADC cutoff of 900.
Yeah, that is weird. Like, because ADC is just a derivative, right? So, and that's how we generate synthetic B values anyways, like for 1500s.
This
So,
is where the debate is. So, I don't know. But well, we'll get back. We're now having a debate with the physicists and stuff. So we'll report back about this. But that's why I was asking you about this one. So
okay, I thought it would maybe because of the signal suppression with high B value, not so much for the ADC, but just for comparison against endometrium. Anywho, well, I guess we'll get a
Nelly,
follow-up.
Sorry to interrupt, but Nelly, I agree with you. I think it's the B value kind of plays into the suppression of the normal tissue. So it would make a difference in the comparison to the endometrium, but I don't think it should matter for ADC, but we're debating still.
Oh, gotcha. Yeah, that makes sense to me. So, all right, well, assuming this is B value of 1,000, there is signal higher than the endometrium. And then you already saw the ADC. I got one area that was below 900. It was this area, I think. So this was surgically resected and was leiomyosarcoma.
that's amazing. So, could show the ADC again. I just see the DWI right here, but because only one little spot was lower than 900.
Yeah, I think it was like this little area.
So we're like hanging your hat on that.
Well, it doesn't matter. You just need to have one area that's like abnormally low, right?
Yeah.
It doesn't have to be all homogeneously like low on ADC.
Show the T2 again, just for one last thing, because I don't like if you didn't get that one area, would you have called this probable fibroid or
no way? No,
because of the
T2.
Because why?
The T2 looks suspicious.
Intermediate.
And abnormal. Yeah.
Good case.
Agree.
So for anyone listening, you can check out the radiology paper by Heinemann et al. In this past year, and it was a consensus statement about leiomyoma versus leiomyosarcoma, and they have a nice little algorithm there with that Nelly just like led us through. So, okay, this was a CT urogram, and we can see that there's some hydronephrosis on the left side. And I want somebody to point out a finding.
The distal ureter has a filling defect.
Has a filling defect, like right there?
Or something, yeah, there's some kind of soft tissue, something causing obstruction or inside or outside the ureter.
Okay, let me just, there was not actually a soft tissue lesion there, but that was probably like the column of contrast hitting the urine.
Oh.
Because there is an obstruction at around that level. There's another finding.
Well, there's like soft tissues that are there's like soft tissue mass or thickening in the left.
Right
yeah,
here?
piriformis. Yep.
Okay, good. There's soft tissue thickening. Anything else? I'll show you the coronal, or sorry, the sagittal. Anyone else? Anyone can speak up if they want. Sorry, it's being a little slow. Okay, so here's my ureter.
Yeah, what is that thing?
Exactly.
Initially, I was like, is that a clip? And I did, I don't know if this patient has a surgical history.
They don't have a surgical history. What do you think this is?
It's like going into the bowel anteriorly.
Yep,
And
exactly. It's coming from the bowel, actually.
wait,
It went outside, and then it goes into that presacral space where it was causing soft tissue thickening. Look at the shape of it.
Is it like a pancreatic duct stent migrated?
That's an excellent thought. Those usually have a loop at one end. This one has like a little bit of a kink, and it was metal. It was pretty bright, right? Super, super bright. So metal, not plastic.
I mean, I can't imagine that someone ingested that. I mean, how do you, how is
They
that
did
even
ingest it.
possible? Oh my goodness.
But okay, I'll tell you what it is, unless anyone has any last guesses.
I know we had like the, is it too big for those, like the little grill things for the
The
barbecue?
grill needle that they have in Arkansas a lot.
Yeah.
Yes, that's too big for that.
The other thing I can think about maybe is like a hair piece, but
It's actually a paper clip. Somebody guessed bobby pin. Good thought. So it's actually a paper clip. So the patient remembers swallowing a paper clip. This is what it said in the note. I don't know why. Like, we don't have further information about why they swallowed it. We later found out that they were actually in jail. Like, so I don't know if it was, that was part of it, like trying to get out of jail, or I don't know what was going on. But this is an ingested paper clip that perforated through the bowel, and then basically nicked the ureter here. So caused that hydronephrosis. And then it's causing this like inflammatory reaction in this tissue here. So we've shown fish bones, we've shown ingested grill bristles, and now also beware of paper clips, beware of sucking on a paper clip.
So this is a 58-year-old male who came in with like elevated PSA. So he had his MR prostate. So I'll just scroll through the images. This is an axial haste. So you can say this is the prostate. And this is haste. This is a sagittal T2. And I will show you. This is the diffusion ADC. And I'll bring the post contrast. So any thoughts?
Is he having pain and fevers? Because like one thing is it just could be like a giant abscess.
No, he did not have any fever.
I'm also thinking about that giant serous cystadenoma of the prostate or seminal vesicle.
Yeah, like that we gave one of that as a differential. We were actually thinking it like we gave a differential. This could either be like a neuroendocrine tumor with like cystic necrosis, which can like present this way, or like sarcoma, like phylloides kind of an appearance, atypical malignancy. Because his PSA, let me see. I forgot what his PSA was. So his PSA was a little elevated, not too crazy for like if you think it's an adenocarcinoma. So this was biopsied and it came back as xanthogranulomatous prostatitis. So I've never seen one.
Wow. I was going to say that post contrast to me just looks like an abscess. So I guess it's kind of in the abscess category, right? Like,
yeah, but he didn't have any fever.
process.
Like he didn't present with any acute constitutional symptoms, no fever, like no white count at that point. So he just came in with like the urologist kind of felt like a big prostate for his age. So they said like, oh, let's do it pelvic MR, prostate MR, and that's how we came down with this. So this was a nice appearance for like an atypical. And also literature mentions when the patients get diagnosed with xanthogranulomatous prostatitis, it's usually a very close mimicker for a necrotic prostatic adenocarcinoma. And the pathology is the one that can differentiate them. And the next differential is an abscess, prostatic abscess. But patients usually present with like severe parectal like examination, like they have like pain, tenderness, and all those constitutional symptoms, which this patient did not have. And for this patient is actually getting treated with some antibiotics. They are not planning for any surgical management in this patient.
I was wondering, I was going to ask if they were going to drain it.
No, they said like it's conservative management with antibiotics, at least by the urology note.
Wow. And what kind of antibiotics is you're saying granulomatous?
Let me see what they put him on. He's seeing ID, like they're taking a culture, and based on the culture, they're seeing an ID person and recommending antibiotics. I don't see the antibiotic.
Do you have the pre-T1?
Yes.
Thanks.
Yeah. So like the articles that I found, the literature mentions like surgical management is reserved for ones who do not recover or get treated with the medical management. It's only like a secondary stop if he doesn't improve. And that's one of my case. I will wait for Nelly's and then like I'll show the next one. I'll pull up the next one.
Okay.
Sounds good. Patient with uterine mass. So this is a companion case, and this is a little bit more abnormal looking, ugly, yeah. So the contrast enhancement, here's this retraction. There's areas of necrosis centrally, peripheral enhancing area, and there's probably an endometrial extension or involvement. Here, there's this kind of extension into the endometrium. And the T2 looks ugly, as already been stated. And then the diffusion is also abnormal. High signal. It's hard for me to even actually trace the endometrium. Maybe it's back here, but higher than the endometrium. And then the ADC is also abnormal. I'm not sure if the ROI is it's not going to project, but areas that are appropriately measured with what mean square of 25 shows low ADC in the 600s, 700s. And this was surgically proven leiomyosarcoma. So
this one definitely looks, yeah,
yeah,
like really
agreed.
dark ADC. It's interesting on the T2 though, like at the top of the lesion, it was super T2 dark, like almost like all that
Maybe
super dark stuff at the top. Maybe that's separate fibroid or something.
Or maybe, yeah, exactly. I think maybe if I had to guess, the T2 intermediate signal here are probably areas of LMS with a normal kind of conventional T2 dark fibroid in the fundal area.
Awesome.
So I really like that consensus statement. I think it's been working out really well for me, and it's great. It's great. I'm looking forward to seeing how it does that in the multi center setting, which I'm sure will come shortly.
Yeah, can you just show everyone the little algorithm that you went through?
See if I can zoom in. So the first step is to rule out extrauterine disease. And then after that, this one, if it's localized to the uterus, then we want to make sure it's enhancing. And then within the enhancing components, look for T2 signal. If it exhibits intermediate or high T2, then we go to high B value diffusion. And the signal has to be greater than the endometrium. And if that's the case, then we move on to ADC. And if there are areas that are less than 900, then we say it's suspicious for malignancy. And the accuracy is supposed to be above 90% using this flowchart. according to the paper.
Awesome. Okay, Anu?
A patient with history of splenic lesion seen on ultrasound, and MRI was performed for further evaluation. So here's your T2. And then here is the post-con. Aarti has shown this case before, so I'm excited to have my own.
I'm biting my tongue. I'm going to let someone else guess it.
So we have this mass here. It has kind of this radiating hypoenhancing region slash scar. On the T2, we have areas of low signal within the splenic mass here. And those are telling imaging findings of this condition. I'm so excited that I have my own now, because
It's a
I
beautiful
think
one.
Aarti, it's a beautiful one.
Yeah.
I think Aarti has shown
I am
multiple
curious
of
in
these
in and
cases.
outs. Is that hemosiderin in the scar?
I think so. Let
Okay.
me show you the in and a post space. Here it
Last
is.
week I showed a literal cell angioma, and it also had drop on the in phase, and that was one of the key features is hemosiderin.
So
So
here's
this is
the
out.
and here's let me see.
Oh, it's not big.
I thought it increased, but maybe the T2 is better. I don't know.
It might just be fibrosis, not actual hemosiderin.
Oh, gotcha.
Okay, last
That's
chance.
fair.
Anyone?
Okay.
It's a
So
SANT.
that's right. I'm so happy to see this case because we've seen Aarti show multiple of these cases. Sclerosing angiomatoid nodular transformation of the spleen. It's a benign etiology or benign lesion. And classically, they have the central scar that's hypoenhancing. And as Aarti already mentioned, you can get hemosiderin, low T2 signal that should bloom in a post phase.
Yeah, they can be tricky because they're large and kind of look ugly, but the T2 dark scar and the kind of spoke wheel appearance, all of that is really classic. So just remember that because you don't necessarily need to resect it or even bring up an angiosarcoma.
Can you keep? So this is a guy with, I'll show you the first initial CT. This was in 2014. He has a history of CKD and he had multiple renal lesions, and then one of them appeared more malignant, like a Bosniak 3. So thick wall lesion, little heterogeneous density. So this one was resected and came back as clear cell RCC. And fast forwarding, he has multiple over time, like he has been followed up, and he had a nephrectomy, bilateral nephrectomy, and he has multiple hypodense lesions in the renal bed. Any thoughts? He has also in the retroperitoneum. All these.
And they only showed up post-op? They weren't there before?
No, not on the, like you can see here, his retroperitoneum did not have anything else.
They don't look solid enough to be like splenosis.
Yeah, because he still has a spleen, like with all like.
Yeah, intact.
Yeah. So he has multiple of these. So we did an MRI and T2, these are the locations.
This is weird.
Yeah, I'll show you the post contrast. And these like cystic lesions are like increasing in size over time, very slowly, but they are increasing in size. All of the, like they were non-enhancing, cystic appearing. And he also had like one in the esophageal wall as well.
Is it some kind of treatment related,
Like
immune therapy or?
No, he was not on immunotherapy. Like we checked
Okay.
all those, like he was not on immunotherapy. So we were like wondering if it could be from, and his distribution was like kind of more retroperitoneum compared to the others. We were wondering if this patient had any kind of like lymphatic obstruction. And there was like one article which was mentioning like patients could have like cystic metastases if there was lymphatic involvement in these. I couldn't get the first initial pathology to see for those details, but like we are wondering if it's because of that he's having cystic metastases. All of these are cystic metastases. We haven't seen anything like that, but there was one article like I have to like pull up. I saved it somewhere, but I can pull it up. So if any one of you have seen, that'll be great for a consensus, but I'll keep you posted eventually if they kind of, we said like can be sampled to confirm the diagnosis. We have to see what it's going to come back as. Have you?
We need the final path. This is so interesting.
Yeah. Any one of you have seen anything like this?
No.
None of the lesions like enhanced. Everything was like cystic, but it's been growing. So that's what makes it like more suspicious, because over time it's like slowly, gradually increasing in size and like number as well. So we said like if they can't get to the retroperitoneum, at least like EGD wise, like they can go and get this sample of this one lesion if they could. I don't know if they can see it. It looks like it's in the wall. I don't know if they can visualize them, but this was looking really weird. I can show you on the coronal. It's like the distribution along the vessels and like the lymphatic channel. So that's why we thought like maybe it's because of that. So I'll keep you posted on this. They haven't done anything yet though. Okay.
No idea. I'm thinking, you get cystic disease of dialysis in the kidney, and like maybe there's something about dialysis that can induce it, but I think you have to exclude, especially if they're enlarging, you have to exclude Mets.
Yeah.
I do know like some RCCs can look very cystic, like in VHL, they look very cystic, but actually the entire cyst is lined with RCC cells. So
okay.
could be some weird variant.
Like because when I went back to the initial one just to see if the primary was very similar, but like in the primary was a very clearly cystic RCC too. So that's why like had a suspicion if it's like something similar, and to like get a sample and check it out. We have to like wait for the pathology.
Yeah. Let's show this one. Okay, so this patient came with abdominal pain, and there is this lesion finding in the pancreas. What do you guys think? I can show you the coronal as well.
I mean, it could be acinar, like pancreatic cancer, acinar variant, which can be kind of big like that in the pancreatic tail.
Yeah.
Presumably, does you can have focal pancreatitis.
Good
Like
thoughts. So like maybe a
IgG4 can be
collection.
focal.
So we're thinking either necrotic adeno, an acinar cell, a fluid collection from pancreatitis. Looks
Malignant
pretty
IPMN.
IPMN, good thought. And maybe even like with malignant degeneration. It looks like there may be some soft tissue components. Any other thoughts? And would you recommend tissue sampling, MRI, what?
This is the initial presentation.
Yes.
And like you said, abdominal pain.
Yeah.
Hmm.
But
And
like
we ruled out
vague abdominal pain. Lipase was not elevated.
IgG was normal presumably.
No, it was normal.
Then I do an MR.
Okay. And I guess that's one of the questions here is like, whenever we see a mass like this, like if, we brought up at like necrotic adeno, acinar cell, like, do you guys recommend an MR for all of these or?
I think if it, in a nationalized country, I would probably, they would like go straight to EUS. I think that MRI can add some value, although I don't know that it'll warrant the cost associated with it.
Yeah. Okay. So they went to US. I'm not going to tell you the results yet. And then they got an MRI. And this is what it looked like on MRI.
Do you have the subtraction?
Yep. But what do you guys think even just about this T2?
I would put MCN in there. serous cystadenoma.
Yeah, so it's super T2 bright, right? And actually, I would say I would not put MCN in there. And the reason why
Oh,
is
because it
MCN
doesn't
has a
have the
capsule, and so
capsule.
it doesn't
Yeah.
have this lobulated border. It should have a smooth and a mildly thickened border, whereas serous cystadenoma does not have a capsule. So this to me actually looks like a pretty typical serous cystadenoma. With a lobulated border, multiple septations. And this is where one, I think it can be tricky on CT. So if anything ever looks cystic, just keep it in the back of your mind. Like, is there any possibility this could be a serous cystadenoma? And if you even think that at all, recommend an MRI. So this is what it looked like post-contrast. I would say it can even be tricky post-contrast because it has so many septations that it can look, enhancing. You can see a lot of these septations are enhancing. I'll show you the subs. So I don't think that the post-contrast really help on MR and definitely not on CT. But I think what clinches it for me is the T2. But anyway, on EUS, they said it looked like a classic serous cystadenoma on EUS, like a very spongy honeycomb appearance on EUS. And the histology was all negative. So on EUS, serous cystadenomas will be paucicellular. So usually you won't get many cells. And it might have serous appearing fluid. It should have low CEA and low amylase. So yeah, this was just a super tricky one. We all looked at this a lot on re-looked at the CT and just thought there's no way that on this we weren't thinking, we were all thinking like this is like a necrotic mass, but in retrospect, maybe it looks kind of lobulated, maybe it looks kind of cystic. We could have saved them an EOS by doing an MRI.
I don't know. I think if we did that for all cases that look like that, you'd be doing a lot more MRI than it's warranted.
Yeah. It's just a tricky one, right? It's a good reminder.
Oh, yeah. And I think the sequence of events for this case is totally appropriate.
Yeah. Okay.
So this was an interesting patient. He is like a 27-year-old. I'll show you the most recent one. So this is like in December, not the most recent. So this is, I'll scroll through the case and then you can see patient has history of Crohn's, and then he's coming with acute abdominal pain. I'll scroll through slowly. Sorry.
There's extensive pneumatosis.
Uh-huh. And he also has air
And
air
mesenteric gas.
Yeah. So we call this as suspicious for like bowel ischemia, like free air. And then like the surgeon called and said like, oh, are you sure? Like, I said like, yeah, we see all these findings. It's suspicious, like dilated bowel loops as well. And then he said like, can you check with his prior from like June and say if it's improved or worse? And this is from his June CT. And he has like pneumoperitoneum. And he has like similar appearing bowel pattern, like free fluid and everything. And this is one after his December CT. And you can see like all of them have resolved, like except for some free fluid and stuff, but his pneumatosis and everything has improved. So this guy has been waxing and waning in his appearance. Like he gets this pneumobilia, like mesenteric gas and like pneumatosis and also like pneumoperitoneum. And then like this, he has undergone like multiple surgeries, and every time they go in, there's like nothing acute. They don't find any air leak, like no bowel perforation, bowel is intact, like there's no bowel ischemia, and they close and come back. So apparently this is something I learned from the surgeon. So this is, the patient has a JAK2 mutation, and patients who have this JAK2 mutation in them have increased bowel permeability. So the air and the fluid like increases the permeability of the wall. So they move out of the bowel, not necessarily as a perforation, but by increased permeability and during an acute episode. And then like when they go in and see in the intraoperative field, there is nothing happening. They close out and come, they recover. So this patient has been in multiple times in the ward, and not once they found a perforation or bowel ischemia. So they said like this is related to his mutation. So I've never heard of this etiology. So I thought it was interesting to like at least know about this one.
Yeah, that's super interesting.
Yeah.
One question, you said pneumobilia, you meant portal venous gas?
Sorry, portal venous gas. Not
Okay.
portal venous gas.
Just, can you just show that? Because that was like pretty extensive portal venous gas. And it's a nice example of how it tends to go branching and peripherally, whereas pneumobilia will be like more central.
Yeah.
Because that's the direction of flow of the bile. Wow. And then the dilation of the bowel, is that just from just kind of chronic?
Yeah, from his all Crohn's, and like I think he like has a transient dilation. We don't see a acute transition points. Then he kind of resolves. And I asked the surgeon, like, not once you found something. He even has like gas in the veins, and he's like, yeah, we never found once, like multiple times, and we want to know like if it's worsened from his worst ever looked CT, and if it is the same or less than that, we're not taking him to the OR. So that's what he said. I was like, wow. So
wow. And can you spell it out for us? You said a JAK mutation?
Yeah, JAK2, like it's like the
Okay.
alphabet, like JAK2, capital J, capital A, capital K2 mutation. And I was
Okay.
trying to read up, and the only thing that kind of relates to it is the increased wall permeability.
But on one of the CTs, there's quite a free fluid, and there's the peritoneal, there's thickened, and so even with those imaging findings, it was still
like there's nothing in there. Like every time they go in, there's not even like bluish appearing, like nothing they found. So he said, like, I was like surprised. He's like, yeah, like he said, like, it's beyond my understanding to say, but it's like the physiology of the JAK2 mutation is what's causing this apparently. So we don't want to take him to another one because it increases the risk of like adhesions and other things, despite having his own Crohn's. So they said like they were not taking him for surgery, and he gets acutely admitted. But then he is in the hospital, he gets us all this imaging, they can manage him conservatively, like after multiple surgeries. Then eventually when he came in, they manage him conservatively and he goes home, fine. So they haven't found a reason why he's developing it. So they're attributing it's because of the bowel wall permeability, because not once when they went to the OR, they found a perforation or obstruction. So
very cool. We will all read more about it.
Yeah.
Okay, so this patient presented with right upper quadrant pain. I'm going to show you the coronal as well. Obviously, there's something going on here. This is what the gallbladder looks like. I'll show you the coronal. So what do you guys think is going on here?
my differential would be gangrenous cholecystitis. There's like, yeah, and I was wondering if there's like a node there. Is that, but
That?
yeah, I'm not sure that that's a node. Maybe.
So you're thinking gangrenous cholecystitis that has like, that's like kind of extending into the pericholecystic space.
Yeah, I think gallbladder cancer. I mean, it would be so hard to differentiate those two right now with what I see.
Okay, good. So that was what was initially thought. And I can see why you think that. The gallbladder looks crazy. But I would like to draw your attention to like the stomach. You know, the pylorus of the stomach is actually pretty thickened here. And
yeah, and there's like mucosal something.
Right. And there's all this like soft tissue. So then when we started thinking about that, I mean, I think it's still something you could give a differential about, but we're like, okay, this kind of looks like, okay, if it's not just an inflammatory process, could there be a malignancy here? And if there's a malignancy, do you think it's gastric or do you think it's gallbladder? And then as we kind of looked at it more, we're like, you know, the process is kind of like exophytic from the gallbladder. So we thought it might more be a gastric cancer, like a pyloric cancer that has spread onto the gallbladder and causing kind of cholecystitis, maybe even a fistula. We thought there was like possibly a fistulous communication between the stomach and the gallbladder. And then actually this patient got a follow-up. This was the follow-up. And you can see that the pylorus is still really thickened. The stomach is still really thickened. It looks really abnormal. The gallbladder still looks really abnormal, although now it's less distended and it has a thicker wall. So, you know, then people are like, oh, it still could be gallbladder cancer. But I will tell you, in the end, this turned out to be gastric cancer. So I guess a couple of the teaching points are like, one, when you see something that looks inflammatory, you know, always think like, could there be an underlying cancer there that's causing an inflammatory process like a fistula, or it's causing obstruction of the cystic duct and therefore causing a secondary cholecystitis. And then two, if it looks like it's, you know, find where you think like it's really centered, like if it seems exophytic to the gallbladder, then it's less likely to be gallbladder cancer. Although you can still give the differential, but in this case, we kind of favored gastric, and it turned out to be gastric. And actually, by the time of the follow-up, there were some additional findings, like, you know, there's these nodules here in the omentum. These would still probably be considered local. You know, it's kind of like if you have a gastric cancer and you have nodules or nodes nearby, you know, is it actual peritoneal disease or kind of more localized spread? So my surgeons have told me that, you know, they hedge towards like, okay, we'll see if this is localized, but we'll do a laparoscopic diagnostic laparoscopy and see if there's peritoneal disease elsewhere, which we didn't see. So anyway, just an interesting case that kind of mimicked a gangrenous gallbladder, but was actually a gastric cancer fistulizing or obstructing the gallbladder. So Nelly was just asking if, you know, if it was just cholecystitis, why does it look kind of gangrenous looking? And that's where we think that there actually is like a possible fistula with, so like we were thinking like maybe gastric juices were going into the gallbladder.
Gotcha.
Because it looks like it's, you know, there's a connection and communication right here, but yeah, I can't, you know, it's not your just classic normal gangrenous cholecystitis, you know, it's related to this process next to it.
So this is a young a patient who I'm just not going to tell the history for now. You can check for yourself, and then I'll tell you the history. The history makes it very obvious. So this is what we find. So it's a non-contrast exam of the chest, abdomen, and pelvis. The patient had give the history. Patient had an abdominal pain and history of heart failure, long-standing history of sarcoidosis and acute on chronic respiratory failure. So the previous day, the patient had a thoracentesis and then another procedure. And then they wanted to check post-procedure CT.
So they've had a prior lymphangiogram.
Yes.
Because there's lipidol in their lymphatics.
Yeah.
I'm thinking maybe did they have a chylothorax, like a chronic chylothorax, and then they had to embolize it?
Yeah. So this, like initially when the resident put in the report, they said like, oh, multiple calcified lymph nodes in the chest, abdomen, pelvis from sarcoid. But actually we checked, this was like 6 months prior CT chest and did not have all those calcified lymph nodes, what they kind of claimed. So that made us go back and look at the procedure, because they only gave, like the clinician gave a history of like thoracentesis. And then we obviously had other procedures, went back and looked, none of these were there. So these are just lipidol from the lymphangiogram procedure that they had the day before. So all this is just contrast, but not calcified lymph nodes. So just wanted to show it for like the residents to know, like this is possibly from that, have that in the differential in the mind.
Yeah, so usually they inject the other, you know, between your web spaces of your feet, and it's a very long procedure. And then they track the lipidol as it goes up the lymphatics, and then they try to gain access into the cisterna chyli, which is in the retrocrural area. Here it looks kind of, yeah, they'll try to get into one of those channels. Actually, right there. Oh no. Wait.
So the level of L2.
Yeah.
Yeah.
And then they'll try to get up into the thoracic duct and then either embolize or sclerose the thoracic duct, usually in the setting of a chronic chylothorax.
So this was a good example.
Do you know why they had a chylothorax? It's usually like post chest surgery or trauma.
They had some procedure, and following that had a thoracic duct injury in the neck. And that's why he had a chylothorax. female, sorry, she had a chylothorax. Some procedure-related thoracic duct injury, iatrogenic. So
I have seen my IR guys to do a really cool alternative now where they can actually by ultrasound find the thoracic duct in the neck, right next to the brachiocephalic vein, and directly cannulate it there. And that prevents having to do this whole lymphangiogram procedure.
well, that's cool. Yeah.
Yeah, but it's not always that you can see it. So very cool. Okay, I think we're going to stop for today. Thanks, everyone.
Thanks, everyone.